Hello, Dr. Childers here. I'm in my Vitae series, and we're up talking about the period of time when it's at UCLA, Keith Nectarline, and the aftercare program. Another point of importance about my period of time with the aftercare clinic, a knowledge and information that kind of guides who I am in clinical practice, has to do with a question that emerged at the clinic and its resolution. And so I want to take you back to this issue that was discussed at the clinic and how it was resolved to give you a sense of my value system and what I bring in the application of everything I do. So I'm going to take you to a staff meeting. It was a weekly staff meeting, all clinical staff meetings. So there were about 4 case managers there, one or two of the diagnostic people, Joe Ventura, Michael Green from the diagnostic unit, the psychiatrists, Michael Gitlin, George Bartzokas. Michael Gitlin was a phenomenal psychiatrist. Wow. He knew his stuff. He knew his neurobiology, he knew his medication, he knew his diagnosis of psychopathology really well. He was a pleasure to listen to in these consultations. And then Keith Nectarline as a project head would be at these meetings. And Karin as the secretary for administrative purposes. I was there representing sort of the testing data side of things because I would be tasked with following through on anything that came out of the clinical discussions. So if a patient was relapsing or exacerbating or whatever decisions were made in that clinical meeting, I would be the one to implement the data research side of that decision. So I got to participate in these clinical meetings. Fascinating stuff. So Rosemary, who went out and screened at the hospitals, would bring into these meetings her screenings. So a new patient, and she would present the data, and then Michael Gitlin and George Bartzokas would offer about diagnostic, and we had the other, or if a patient was having difficulty with family or in the community, functioning problems, that would be brought in. Sally or Rosemary would bring in their patient information, and the case managers, Keith and Keith Nectarline and the psychiatrist would talk about how do we respond to the clinical care issues of the patient. And so there was some fascinating both diagnostic discussions as well as treatment-related discussions for the patients. Now, because this was a clinical research project, the standardization, the research protocol required that all patients be treated the same, so that any differences that showed up in their symptoms or course of their illness would be due to other factors other than the quality of treatment they were getting. And so this treatment had to be standardized across 4 case managers, across 2 psychiatrists, across all the patients. And so one of the ways they did that was with injectable antipsychotic meds. So it was 12.5 milligrams of Prolixin injected every 2 weeks, and that way they had a stable baseline of medication. Everybody had the same medication. Well, it kind of came forward. And the issue with medication is medication causes side effects. And so long-term side effects is this thing called tardive dyskinesia, where you get a Parkinsonian tremor. And so the patient develops a tremor because of the dopamine. It's a dopamine medication, and dopamine is a motor system. So they develop Parkinson's disease, basically. And it's irreversible. Once they develop the Parkinson's, it's done. It's called tardive dyskinesia. And so it was these clinical discussions, one of the interesting ones was when the patient started to show tardive dyskinesia, the question is, do you stop their medication to prevent the continuing development of the tardive dyskinesia, the Parkinson's, but then they're going to go psychotic? Or do you manage their psychosis and they're going to develop irreversible Parkinson's? Yikes, what a difficult decision. And these are for patients who are 30, so they have a life ahead of them. What a difficult decision that was, and to hear that discussion around that issue was it. So we want to keep the medication low enough so that the risks of developing tardive dyskinesia are reduced, but we also wanted to control their psychosis, because every time it's a progressive disorder, so every time they relapse, they never quite recover to the full extent. And so over the course of time, they go through these relapses and they gradually deteriorate because every relapse, they don't never quite recover to the same level of functioning. And so we want to reduce the number of relapses. If we can reduce the number of relapses, they can stay functional at a higher level. So we want the medication to control symptoms, but we want to keep it low enough so that they reduce the risk of tardive dyskinesia. 12.5 milligrams per Lixin was the set point that they decided was the appropriate level to meet both those criteria. But some patients, their symptoms weren't maintained on the 12.5 per Lixin. Others, they were maintained too much. We had one patient who needed 6.25, half a dose. That was better for them. And because otherwise they'd start developing some of the tongue thrusting kind of physical symptoms. For other patients, we needed a higher dose to be able to get a cap on their psychosis. And so the question came up in these staff meetings, these clinical care meetings. What do we do with these patients who need a different medication? Because that breaks the standardization of the research protocol. So we have the clinical care team, the social workers talking about the patient's symptoms, the psychiatrist talking about the medication response to those symptoms, and Keith Nectarline kind of organizing that and providing direction as to the overall research requirements, the program requirements. And so we listen to these discussions going back and forth. And the issue for Keith, the issue for Dr. Nectarline was, how do we standardize patient care when patients need different quality of care? One patient needs higher medication, one doesn't. So what do we do about the question of standardizing care? So the first thing Keith made absolutely clear is we will do whatever need the patient needs. So forget the research. The first priority is patient care. Now, second priority, God darn, how do we deal with standardization of treatment? And I thought the solution that Keith came up with, Dr. Nectarline came up with, was fantastic. Beautiful. Perfect solution. His solution was, the way we are going to standardize patient care is we are going to give the highest caliber of care to all patients. So every patient will receive the highest caliber of care possible. That way they're all receiving the same care, the highest possible, the highest caliber possible. Now, for some patients that might involve higher medication. For some patients that might involve lower medication. Some patients that might involve family therapy. Other patients that might not involve family therapy. So the actual care they receive may vary, but it will be the same for all patients because every patient will receive whatever they need, the highest caliber of care. So if one patient needs family therapy and the other doesn't, that's okay. Because that one needs it, this one doesn't. This patient needs a higher medication, that one doesn't. That's okay, because this patient needs a higher, and this one does. And so that was, I thought, a marvelous solution for standardizing care, the highest care as standard possible. And so I bring that value system not only to my work with everybody, everywhere, all the time. That is the highest caliber of professional service, but also in the ABPA pilot program. That is a value system I want to inculcate into the program because the ABPA pilot program is set up to join with university research projects. I know university research, 15 years, 12 years with Keith Nectarline, major university research project, networks into multi-site, multi-people, multi-investigator, major UCLA longitudinal research. I know clinical research projects. Our testing battery was 8 hours, started at 8 hours. It was 16 hours of testing battery by the time I left. I know clinical research protocols. And so what the ABPA pilot program structured is it's structured to accept and to join with a university collaborator. And one of the ways to standardize the treatment within the ABPA pilot program, the treatment model is solution-focused family therapy. And so it's a very defined treatment model, family therapy, add solution-focused therapy on it. And it has a nice protocol to it, and there's structured, the treatment. Continued visitation schedule, the use of the parent-child relationship rating scale, kind of stuff. But one of the ways to standardize the therapy is by ensuring that all clients of the ABPA pilot program, all families, receive the highest caliber of care possible. Everybody then receives the same quality care. Everybody's receiving the same care, the highest possible. Some families may need the continued visitation schedule, some might not. Okay. But they are all receiving the same care, the highest caliber possible. And it also serves, that highest caliber principle, also serves as a nice guiding focus for resolving decisions. So if you have a question about what should happen, the question becomes, what's the highest caliber of care for that question? Then let's do that. And so that's a nice guiding principle for decision making throughout the project. And that comes from my work with Dr. Keith Nectarline, UCLA Aftercare Clinic, longitudinal research on schizophrenia.